So, good night or good afternoon, everyone. This is Internal Medicine Endocrinology. For the USMLE Step2CK, I'm going to assume you know most of the stuff that's in UWorld. I'm just going to point out a few things that I think people get wrong, and hopefully this will help you guys. So this is for endocrinology specifically. So the first thing I wanted to discuss was the effect of thyroxine binding globulin and the effect of like certain medications on thyroxine binding globulin. Obviously, know what pregnancy does to thyroxine binding globulin because they ask multiple questions about that. But and know the correlates. Like, not don't only just know what tamoxifen does to thyroxine binding globulin. Also, kind of know also kind of put this in clinical context for yourself. Like, think about like a premenopausal female that's being treated for breast cancer. If they're on steroids, think of a person with rheumatoid arthritis. If they're taking androgens, think of a person with testosterone replacement therapy. So just know the clinical correlate, because I'm going to show you the thing on the next slide. And I imagine, like, on this slide, again, a lot of people already know this part. They know that levothyroxine absorption, like, you can take vitamins you want to take on an empty stomach early in the morning, but they kind of forget all these other ones. So just know that. And then another last point I want to make that's not on this slide, you can go and pause the slide and like see how much of it you know and memorize the rest. Is that sometimes patients have concomitant celiac disease and they're not really absorbing their thyroid hormone really well. Um, and this is kind of common because if you're taking thyroid hormone and we're assuming you have an autoimmune process that's making you hypothyroid, celiac disease is an autoimmune disease, so those two kind of go hand in hand. So you might be finding that we're increasing the thyroid hormone dose and they're not really responding that well, and it turns out the patient has celiac or something. So just keep that in the back of your mind and memorize all the interactions on this list. Moving on, again, if a patient's hypothyroid, everyone knows that we give either PTU or methimazole. Remember which one we give first in pregnancy. You guys probably already know that. The reason I put this up is I wanted to point out this thing, that if WBCs drop, if they get agranulocytosis less than 1,000, you got to stop the medication. That's it. It's over. And if WBCs are still greater than 500 and they're still low, it's probably not the medication and you can continue. Again, if they have agranulocytosis and you stop the medication and they become febrile, so we call this neutropenic fever, and we want to treat this really aggressively, and that's why we're covering for pseudomonas and all this other stuff, because the patient can like get sick really fast. And then the last thing that I wanted to point out here is what did I want to point out? I've forgotten what I wanted to point out here. Oh, if you're treating for hyperthyroidism, obviously you're going to give methimazole. That's what we most commonly treat with. And the patient will come in, they'll have tremors, palpitations, tachycardia, diarrhea, all the hyperthyroid symptoms, the classic ones. Just again, consider choosing propranolol before you give methimazole. Don't just jump to give methimazole. Propranolol will work instantly, and methimazole will take a few days to kick in. So just don't make that mistake of jumping directly to methimazole if you want to treat it. If they want to ask the first therapy, maybe consider giving propranolol and also giving methimazole, but give them propranolol right now so they feel better. That's just the point I wanted to make. So these are fancy adverse effects. These are within the table in UWorld. I've just copied this from here. Everyone knows that methimazole causes agranulocytosis. Remember, it also causes cholestasis. PTU also is like hepatotoxic. Remember, it also causes an ANCA-associated vasculitis. So these are just ones that probably slipped your mind, but I just wanted to highlight them here so you remember. The next one is labs and hypothyroidism. Hypothyroidism just is associated with a bunch of lab abnormalities. There's hyperlipidemia. Thyroid hormone is great for your lipids, so if you don't have thyroid hormone, this is the reason. You can pause the video and take a read at it. Also, elevations in creatinine kinase. That's also common in hypothyroidism. And this last one, hyponatremia. So thyroid. What thyroid hormone does is it makes your heart go fast, right? It's a common cause of, like, not a common cause, but it causes secondary hypertension. So when your heart goes fast, your body thinks that, oh, my heart's going fast. So you kind of pee out a lot of water because your body thinks that I have excess water in me and I have hypertension, so I should pee it out. So the opposite happens in hypothyroidism. What happens in hypothyroidism is your heart's going really slow. So your body's like, hey, my blood pressure is really low. So I will secrete much more ADH to hold on to water to raise your blood pressure. And when you hold on to more water, you will have a dilutional hyponatremia. So that's why we see this hyponatremia. If I explain this too fast, you can pause and just Google thyroid hormone and ADH and you'll pretty understand what I'm saying. Again, also remember that a common mistake it's made that hyperthyroidism does cause hypertension. Hypothyroidism also causes hypertension sometimes. So now that we're grown up, we're not always going to think hyperthyroidism, hypertension. Hypothyroidism also can cause hypertension. If you don't believe me, just go look it up. I'm not going to go into detail on this, but it can also be a cause of hypertension. So the next thing is, if you have a thyroid nodule, I just want you to recognize suspicious features of the thyroid nodule. I just wanted to point out that hypoechogenicity. You'd probably think the hypoechogenic, yeah, like that's chill. Hypoechogenicity is associated with an increased risk of malignancy. This table is from UpToDate, so if you learn this now, this will be good for your entire medical career. So hypoechogenicity obviously it's an increased risk factor. Isoechoic or anechoic is the one that you're thinking that's no risk. That's what that is. And then all of this other stuff that you probably already know. And then a cool one here that I want to point out is taller than wider. So if the thyroid nodule is like more this way than it is that way, you know what taller than wider means. That's kind of associated with increased risk of malignancy. It's just a cool fun fact to know. This is the same thing taken from a UR table. Obviously, you recognize that if it's solid, if it's greater than 2, if they're microcalcifications. These are buzzwords, like students really know to pick this up. But hypoechogenic is the one I wanted to focus on. That's it. That's associated with malignancy as well. So just know that. And then taller than wide for like the funsies, right? Know that for the funsies. So the next thing is I wanted to go up the workup in detail. So the workup of any thyroid nodule will start off with a TSH and a thyroid ultrasound. If TSH is low, that means that the gland is hyperactive. You're going to do the radioactive iodine. You probably know all of this. I'm not going to go into it. I wanted to go in if the TSH is high and it's a hypofunction, it's a cold nodule, you're going to get an ultrasound. And if they're high risk, you're going to get an ultrasound. So if the nodule is greater than 1 centimeter and with suspicious features, obviously FNA that. If the nodule is less than 1 centimeter and it's clearly cystic, it clearly has all benign features, you can follow up on it. You don't really have to biopsy it. If the nodule is greater than 2 centimeters, you are going to FNA that thing. You're going to FNA it regardless if it's cystic, whatever, you're probably going to FNA it. I just wanted to go quickly over the workup. Another thing that I just wanted to point out is assuming the person has if they'll give you like the person has a previous history of like thyroid, like a resected like papillary carcinoma of thyroid or follicular carcinoma of thyroid, and now they're on thyroid replacement. The thing is, when we're replacing these people's thyroid hormone, what's happening is so TSH is now a trophic factor for the cancer. So our goal is to decrease this TSH as much as possible. So we're giving like a high dose thyroid. So we're putting them on 150, 175 or something. And we want TSH to be undetectable or less than 0.005. So my point being is you're going to see they're going to give you a stem. They're going to tell you that this person had papillary carcinoma of thyroid or follicular carcinoma of thyroid, and they're on appropriate therapy. And the question is going to be about something else. They'll give you a bunch of labs, and then the labs you'll notice that, hey, TSH is super low and T4 is a little on the higher side. And don't decrease the dose of the TSH. This question has probably nothing to do with the thyroid hormone. They're just trying to trick you into showing you a super suppressed TSH and a little high T4. And that's what we want. Remember, that's what we want in these patients. If TSH is in the normal range, we don't want that. We want TSH to be super low because TSH is a trophic factor for their cancer, and we don't want their cancer to come back. So just kind of like see that. This is a big mistake primary physicians also make. They'll see this and they'll think, oh, this person's now hyperthyroid, we should lower the dose. No. If they have a past medical history of cancer, you want the TSH to be as low as possible. And T4, even at the higher side, you will tolerate that. So that's just the point I wanted to make. Now let's just start. That's everything I had to say about thyroids. You guys probably know everything else. Now let's talk about parathyroids. I just wanted a quick word about calcium. Remember to correct the calcium. This is common in patients with cirrhosis, so you're going to need to calculate the corrected calcium. Then another thing I wanted to point out is one cause of hypocalcemia is hypomagnesemia. This is common again in alcoholics. I'm actually going to escape so you can read the entire thing. So this is common in alcoholics. So they're going to tell you that he's alcoholic, his calcium's not coming up. What's the problem? It's hypomagnesemia. You're going to correct it and his calcium will correct. Another cause of hypocalcemia is severe hypermagnesemia. So this is in someone with preeclampsia. You can pause and read the slide. And how you spot hypermagnesemia is you look for apnea. So you look at the respiratory rate and you look for hyporeflexia. So I don't know if you guys have ever done like obstetrics or whatever, and in those cases when we're giving magnesium sulfate for eclampsia prophylaxis, they tell you that, hey, keep monitoring the respiratory rate, keep monitoring the reflexes. If those things start to change, you're going to tone back on the magnesium. So just remember that hypomagnesemia can cause hypocalcemia. Hypermagnesemia can also cause hypocalcemia. Moving on. This is the same thing. You can pause the video. This is just written in text form for you guys to read. So now we're going to move on to the adrenals. That's everything I had to say about the parathyroids. I just wanted you to know that obviously we know that like if we give exogenous steroids, that can cause adrenal insufficiency. This is just a little bit detailed, like doses greater than 20 milligrams are the doses that are a problem for more than 3 weeks. Those will cause adrenal insufficiency. Low dose prednisone for less than 5 milligrams per day have minimal risk, but even these, if you give really, really long term, this can be risky. But just notice that 20 milligrams and up, like above 5 milligrams, is the one that we're kind of worried about. And there's just a fun fact about warfarin written here if you guys want to read it. So causes of primary hyperaldosteronism. So everyone knows cones and whatever. You guys probably know all of this, that like you do plasma, like the aldosterone level, the renin level, you take the ratio greater than 20. The reason I put this slide up here is that is how you screen, right? So you screen with plasma aldosterone concentration to renin ratio. If that's greater than 20, you're now suspecting primary hyperaldosteronism. You will go on to confirm this diagnosis. How you will confirm this diagnosis is you're going to sample the adrenal vein. That kind of seems crazy, but that's how you really control. You get a catheter, you take a sample from the adrenal vein, and you test it there. So adrenal venous sampling is needed to distinguish. So that's just the point I wanted to make. You can pause this. This is the table from UWord, so you revise things. This is again more of the same thing. So elevated plasma aldosterone and to renin ratio, you're going to do an adrenal suppression test. If adrenal I think I got this wrong. Yeah, adrenal venous sampling does not confirm the diagnosis. Adrenal suppression testing confirms the diagnosis. So you're going to give them a bunch of salt and you're expecting aldosterone to go down, but aldosterone doesn't go down. That confirms your diagnosis. Now that you've done that, you've done adrenal suppression testing, it's turned out to be positive. That means that you've given salt and it's suppressed. So now you know that there's a problem within the adrenals. The adrenals are responding. Yeah, they're responding shittily, but they're responding. So you know the problems with the adrenal gland. I just wanted to point out the bottom part of this. This is kind of unique. It kind of goes like against how you would like rationally think about it. That's why I put this here. You can pause it and kind of go through this in your head. I'm sorry for the mistake I made earlier. So just know how to screen, know how to confirm the diagnosis, and then know how to. The next step will involve like adrenal venous sampling. So next thing I want to talk about a pheochromocytoma. You probably know a lot about a pheochromocytoma, but I just wanted to point out a few things. The first thing is how we're going to test for it is we're going to test plasma-free catecholamines if they're within a crisis right now. That means it's within their plasma right now. And if they're not in a crisis, we need to get 24-hour urine metanephrin. 24-hour being the key word. We can't just get a spot urine metanephrin. That's not going to work. So we're going to get a 24-hour urine metanephrin or a VMA, vinyl mandelic acid. The reason I put this up here, you guys probably know all of this, that alpha before beta, everything. You guys already know all this. I wanted to point out an interesting situation that arises that like maybe a kid will have ADHD and pheochromocytoma. I know like that's unusual, or an adult will have ADHD and they also have pheochromocytoma. You like the thing is, right, remember ADHD is treated with amphetamines, or if they're taking amphetamines, Adderall, anything, what do those drugs do? Those drugs increase the secretion of catecholamines. So sometimes what might be happening is they're taking a drug that's increasing the secretion of catecholamines. Catecholamines will break down into vinyl mandelic acid or metanephrines. You will see those things in the urine and you will think that, hey, this guy has a pheochromocytoma, will be mildly elevated or whatever. No. You're going to be smart. You're going to know that this is a very rare instance, but if they're being treated for that, they're taking Adderall, they're taking methyl like phenidate or something, an amphetamine. These urine metanephrines that I'm seeing, that's from the the normal body release. So kind of stop those medications, swap them to atomoxetine or something that isn't like a sympathomimetic, and then test the urine. And then still, if they're having metanephrines and vinyl mandelic acid in their urine, then it's a pheochromocytoma. Because sometimes those patients all like have associated psych comorbidities where they're having anxiety, tachycardia, yada yada yada. So it kind of becomes hazy. So remember, like have this association in your head that, hey, I have to stop like methylphenidate or something before I test for this. So you should know like the features of a suspicious adrenal mass. This is similar like to the thyroid nodule. Greater than 4 centimeters is suspicious. Greater than 6 centimeters is like super duper predictive for cancer, for adrenal carcinoma. High attenuation, greater than 20 Housefield units, and that means that it's pretty solid. And this last one is delayed contrast washout time. You'll see this in medicine a lot, that when something is holding on to contrast for a long time, that thing is probably malignant, because cancer loves blood supply. So it kind of holds on to the contrast. When you give contrast, it just takes up the contrast and it holds on to it for a long time and doesn't let it go. So delayed washout kind of like points you towards cancer. Similar ideas with hepatocellular carcinoma. So just know all of these, that this is when an adrenal mass or an adrenal incidentaloma, if you find one, is suspicious. The next one is about prolactinomas. If you have a prolactinoma, remember that if your prolactinoma is a macroadenoma, your levels of prolactin should be really, really high. Sometimes patients are having prolactinomas. They also may be taking haloperidol or something that causes, those cause hyperprolactinemia, those anti-dopaminergic agents. The hyperprolactinemia that you get from like a antipsychotic, it's not that high. It should be within like maybe 15 to 75 or whatever. If the number is really high, that's a prolactinoma. If the number is a little high but not that high, maybe like 25, 50, 70, that probably might be the medication. So just know that. And then know a second thing is sometimes you can have a non-functioning pituitary adenoma, and it can do this thing called infundibular stalk effect. I think I'll run out of time if I start explaining it, but you can Google it. In a sense, what's happening is the pituitary adenoma is expanding. It's not secreting prolactin yet, and it's compressing the infundibular stalk. And if you remember, the infundibular stalk is the place where dopamine is coming down and inhibiting prolactin. So if you compress that stalk, you compress the coming down of dopamine. There is no dopamine to inhibit the prolactin, so your prolactin level rises. You can like go and check out videos on this or just read about it. It's a really interesting effect. So, and you can pause the video and read the slide. It's kind of explained over here, but just know what prolactin to expect if it's a prolactinoma. Know what prolactin to expect if they're taking an antipsychotic, and know what stalk effect is. The reason I'm pointing this out is like we're grown up now. We should know what to expect. We shouldn't just see a high prolactin and treat that and think, hey, this is from the medication. Know how much of a lab disturbance you are to expect, rather than this will be up or this will be down. So the next thing that I've seen is hyperandrogenism in women. How we diagnose PCOS is, again, it's Rotterdam's criteria. That's the fancy name of the criteria. But know that there should be no evidence of another diagnosis. So rule out other stuff. And another one to rule out is hypothyroidism. Hypothyroidism can cause hyperprolactinemia, which can cause like PCOS type findings. So rule out rule out all these other diagnoses if you can. That's just the point I wanted to make, because all of these can kind of mimic PCOS. They can all cause the same things. And then another big common one is if you're having rapid onset virilization, what that means is less than 1 year, then suspect that it's not PCOS. PCOS is like a slow, ongoing, there's weight, there's adipose tissue making estrogen. If they're having rapid onset virilization, that's probably not PCOS. So at that point, you're suspecting a tumor, an ovarian or adrenal tumor that's making androgens. Ovarian tumors, I just want to point out here that ovarian tumors are making DHEAS, and then DHEAS is so this slide is actually incorrect. It actually says it here. DHEA sulfate is very specific for the adrenals. So if DHEAS is elevated, you know that that's the adrenals. If DHEA is elevated, you know that that's an ovary. So just kind of know that, and kind of know you have to rule out other things before you rule in PCOS. Every fat woman that has acne and maybe has cystic ovaries does not have polycystic, right? What if it's a cystic ovary with some mural nodules and it's a tumor and you're missing it? So just know that you have to rule out other diagnoses. Again, also here, I would just like to point out that know what to expect. If the testosterone in these females is above 400, and if DHEA is above like 800 or 700, that's probably not PCOS. PCOS raises testosterone, it raises DHEA, but not to above like 400 and 800 respectively. If those numbers are in the 1200s, DHEA is in the 1200, know that this is probably not PCOS. That's just another point I wanted to make. So the next one I wanted to talk about is a common clinical abnormality in diabetes. Like, just a common thing that you're going to be testing in diabetics is microalbuminuria. Yeah, we test that to screen, but we also test it when we're controlling them with metformin, and when they're controlling their HbA1c when they're coming back. We're kind of ordering microalbumin again and again and again. So it's not just to screen, it's also just to follow up these patients. Like, it's useless to you that this person has 2+ nephropathy, like 2+ protein in the urine. That's kind of useless. You want to be ordering microalbumin if you're treating them correctly. They should have like, you're ordering the microalbumin. And then if you can't order microalbumin, you're ordering your random albumin creatinine ratio in the urine. That's kind of similar to microalbumin. But know that this is something that you want to be ordering consistently. The next thing is, you can pause the slide and take a read at it. This is just everything that you want to do for diabetics, retinopathy, neuropathy. They have to go to podiatry, all of that fancy stuff. And then the last thing is when you screen them for different things. When you screen them for albuminuria for type 1 diabetic, it's at 5 years. For the type 2 diabetic, it's right then. And know like know the changes in screenings that come along. Know when you colonoscopy people. Know when you colonoscopy people with like primary sclerosing cholangitis. Like know when to screen people for things. Okay, so diabetes can obviously cause gastroparesis. It's autonomic neuropathy. How we treat that gastroparesis is they're just going to complain of nausea, vomiting, early satiety, stuff like that. You're going to treat it with metoclopramide or erythromycin. That's what you can give. Forget this other drug. This isn't approved in the United States, so we don't really care about it for now. You can also give all these other things, which are just antiemetics. The reason I put this up here, right, is they're going to tell you that there's a diabetic patient with gastroparesis, and there are going to be a bunch of options of what medication to give. Do not choose GLP-1 agonists. If you remember, GLP-1 agonists cause gastroparesis in and of themselves. That's kind of how they work. They slow down gastric motility. So it's kind of hard. It'll become hard for you to differentiate that, hey, is this gastroparesis because of the diabetic autonomic neuropathy, or is this GLP-1? So kind of be cognizant of that. That's why I put this up here. Another thing is diabetic neuropathy. Obviously, we know that's going to be symmetrical, distal, polyneuropathy, yada, 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 the fancy words. Know the difference between small fiber and large fiber neuropathy. And then the second thing is there are a bunch of other causes of peripheral neuropathy. So a big one that they like, I think that there you were questions on this as well, is HIV. Also know that B12 kind of mimics diabetic neuropathy, causes subacute combined degeneration. Know all these other ones as well, because they always try to confuse us in questions regarding these. And the last one that's not here that I wanted to point out is, if you remember, diabetes is also a risk factor for carpal tunnel. So they'll tell you that this person has neuropathy, and they'll tell you that it's within like these fingers that I'm holding up. And they'll be like, oh, pins and needles, yada, 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 whatever, right? And they're not going to say anything about these two fingers. They might tell you that there's no neuropathy here. On monofilament testing, these fingers are fine or whatever. So remember, consider carpal tunnel in your diagnosis. Of like distal polyneuropathy. You might be mistaking it for polyneuropathy of like diabetes. It might just be the carpal tunnel. So try to keep that in the back of your mind as well, because diabetes is also a risk factor for carpal tunnel. I actually saw a patient like this today of where I work, and the doctor asked me what it was, and I told him it looks like diabetic neuropathy, but their HbA1c is 6.5. Right? They're great. Why are they having polyneuropathy, and why is it in their legs? So I told him, and it turned out her Tinel sign was positive, and it's carpal tunnel now. So yeah. So everyone knows acanthosis nigricans. I don't know if I'm saying that right, but that's associated with insulin resistance, and obviously look for diabetes and look for like a gastric adenocarcinoma or whatever. This is the other skin derm finding. This is from Up to Date. Necro, I don't know how to pronounce this, but know that if you see this, start looking for diabetes. And you can read the text that's written here, but this is just kind of a cool association of diabetes in the skin. And apparently, according to Up to Date, it was very common. So diabetic neuropathy, we just talked about diabetic neuropathy for a while and its differential diagnoses. What are we going to choose to treat with? If there's an option between pregabalin and gabapentin, give pregabalin. Pregabalin is not given when people in congestive heart failure. It's like we kind of avoid it. So that's just another additional fact to know. Gabapentin potentiates the effect of opioids. That's why, if you notice in America and the United States, why is gabapentin a controlled substance? Because it potentiates the effect of opioids. You don't want to give those two together. Gabapentin on its own just causes sedation. It's not that bad on its own, but it potentiates opioids, so it can cause like a lot of problems. So it's a controlled substance in the United States. Just know what to avoid and when. If they're already taking SSRI, so they'll tell you that there's major depressive disorder and it's well treated, don't give duloxetine. You will precipitate serotonin syndrome. So, and then avoid obviously TCAs in old patients because of it has anticholinergic, antihistaminergic effects. Avoid in cardiotoxicity, you guys probably know this, and avoid in like glaucoma because it will like worsen the glaucoma. So just know when to avoid like what. So this is a Charcot joint. This is a diabetic's foot. Like there's collapse of stuff. They're going to ask you what to do about this. One option is going to say, hey, take this guy to surgery, fix it up, yada, yada, yada. That's going to be the incorrect option. You're going to choose the offload joints and orthotics. We treat this like medically-ish. If you think about it, we don't go to surgery for these patients. Even though they'll give you like a foot, they'll show you an x-ray. The bones will literally be collapsed on one another. All the toes will be weird. You're going to think that, oh, I got to fix this. No. Just medically offload the joints and orthotics. This is just the name for the GLP-1 agonists. So GLP-1s are up here, DPP-4 inhibitors are up here. This is kind of something that we've forgotten. We studied this in step 1. Thiazolidine diones like pio and rosiglitazone. Pioglitazone is also contraindicated in congestive heart failure. And the point I wanted to make, the reason I put this up here is GLP-1 and DPP-4, they do the same thing, but GLP-1 increase, like they have a, they decrease mortality. They're good. There's data on them to show that they're good for mortality. They save patients' lives and whatever. The data is not there for DPP-4, even though essentially they work in a similar manner. And the three adverse effects you want to keep in mind is gastroparesis, acute pancreatitis, and medullary carcinoma of thyroid. That's only proven in rats, but it's there. This is the last slide for today, guys. So this is again about polycystic ovarian syndrome. Again, this is Rotterdam criteria. You need to have 2 out of the 3. Remember, you need to rule out all these other causes first. Just because they're overweight and they have acne and whatever, and you haven't ruled out all this other stuff, doesn't mean that they have PCOS. You got to rule out everything, and then you got to make a 2 out of 3 Rotterdam criteria. And I think here it used to be that you give these people metformin, and then you for ovulation induction, they would ask you like, what do you want to give, and everyone would choose clomiphene citrate, and that used to be the right answer. That's not the right answer anymore. Now the right answer is like lutrazole, no, letrozole. It's the GnRH agonist. That's the drug you want to give. I forgot how to pronounce it. Relin. I don't know what the name is, but that's the drug that we use for ovulation induction in these patients. It's written here. This is incorrect. Go look it up. The drug is not clomiphene citrate anymore. It's actually another drug. It's the GnRH agonist. That's what we use for ovulation induction in these patients. So that's the reason I put this up here. Know how to diagnose. Know that metformin we give. We give metformin sometimes even normally, and we give that other drug for ovulation induction, not the clomiphene citrate. And that's everything. Yeah, hope you guys liked it, and yeah, see you guys in the next video.